Hi there, my name is Chovatiya. I'm an associate professor at the Rosalind University Chicago Medical School and founder and director of the Center for Medical Dermatology and Immunology Research in Chicago. I'm joined today by Melodie Young. Melodie?
I'm Melodie Young. I'm a nurse practitioner in Dallas. I work at Mindful Dermatology and also am a partner and investigator and co-investigator at Modern Research Associates, also in Dallas.
So you're the perfect person to talk this through with me because, you've been in derm for a little while now. So you've had a chance to see evolution in the topical space quite a bit, from a period of time where steroids is all we had to maybe sort of our earliest foray into non-steroidals. And now just really having this big menu of options for potential topicals for atopic dermatitis. And so maybe kind of the first question I want to get your sense of, how has advanced therapy in the topical world changed your ability to treat some of these really tough to treat sites or cosmetically difficult sites or sensitive sites, knowing that we used to have limitations with steroids before?
Yeah, just in general, the first topical calcineurin inhibitors that came out 20 plus years ago, we were using them trying to be sparing with steroids. So we still believe steroids were the thing. And then you would add another medicine to give you a break, sort of the same with calcipotriene. You would use that to spare the amount of steroid use. Now I don't even think about corticosteroids. I think about them for acute situations, bug bites, sunburns, things along, contact dermatitis. I do not think about corticosteroids for chronic diseases. I just think they're not as targeted and they're not as effective, quite frankly. And especially these are long-term diseases, and having these new advanced topical therapies that are very targeted and disease specific has changed my practice probably as much or more than anything in the last decade.
Yeah, it's incredible to think, right? Because for these chronic diseases, I feel like many people just love their steroids, but I think you and I both know that there's a lot of pitfalls, particularly on certain parts of the body, right? So imagine that patient with atopic dermatitis on the eyelids or face. What about the neck? Somebody that sort of has it in body folds under the arms, the groin area, the genitals themselves, even the hands. That's probably not somebody that's going to have an optimal outcome on using a high potency topical corticosteroid for a long period of time.
Yeah, one of the problems you have is if most of the time people who have atopic dermatitis will have it in multiple places. Sometimes you don't always know where they have it because when you see them, it's not active at that point. And so if you give them medium to high potency corticosteroids, they're going to use them in places without your direction. And so there is risk and danger, and I've seen side effects associated with that. So that is one thing. The other thing is I like using therapies that are current and that are based in tremendous science and advancements, and just, trying to do modern dermatology and provide things where we have good evidence to show their safety, their efficacy, and bottom line, that's what they want. They don't want something just to keep them from getting worse. They want something that they can use most anywhere on their body safely, or I want that for them. For my own personal protection, I don't want to worry. I love that they can have one thing that they can use in multiple sites. And definitely not having to worry about side effects is really practice changing.
That's a big piece of the story, right? Because you want to really sort of help your patient and do no harm at the same time. And knowing in the world of atopic dermatitis, approvals for medications like topical ruxolitinib, a Janus kinase inhibitor, tapinarof, an aryl hydrocarbon receptor modulator, roflumilast, a PDE4 inhibitor, a huge menu of options. And I want to sort of pause for a moment and think about kind of topical JAK inhibitors as we've really now understand their ability to be extraordinarily fast, efficacious on itch, and really sort of some of the worst lesions we see in AD is really quite remarkable. And knowing in the case of topical ruxolitinib, we have dedicated studies for eczema on the hands and sub-studies taking a look at atopic dermatitis in some of these sensitive regions like the face, like other areas. How has been your approach to implementing a topical Janus kinase inhibitor for your patients?
Well, a couple of things. One is I think you should do the very best thing that you have for a patient the first time you see them. I hate having to right off the bat say, hey, guess what? You're going to fail You're going to go through things that I know won't work. And to me, the most expensive medications are the things that just stay around in a drawer somewhere. So I do like going for the best, and I want to give them symptom relief really quickly, and I want them to be motivated to continue on with it. So topical JAKs have been the speed, efficacy, particularly with itch reduction. I love them in hands and feet situations. I think about people who, anesthesiologists who have to scrub in. I know a person that literally was on the verge of having to go on to disability because he didn't want to take an oral agent or a systemic agent, tried a topical JAK, and it fixed him. It fixed him. And so their efficacy is very impressive. Topical JAKs also have a lot of variability in where you can use them. And I really don't worry about what they're going to do wrong with it. And that's important.
That's kind of the main piece of it, right? Because as you put it, I know that my patients are only half listening to what I say, and they're going to use anything I give them anywhere they feel like using it.
And share it with their family, because everybody has AD, right?
And so for a medication like topical ruxolitinib, I think you get the best of both worlds, right? When thinking about a lot of the good things that come with an oral Janus kinase inhibitor, but perhaps this isn't the right patient for thinking about a systemic. Maybe their disease is more in the mild to moderate spectrum. Maybe it's just really focal disease. And so you get a lot of those sort of fast, efficacious elements we think about with the JAK inhibitor mechanism in a cream format. And so I think about my patients that have a lot of head and neck dermatitis, and also hands and feet too. They're tough to treat because these are areas that are exposed to so much in the way of personal products, soaps, chemicals, environment, and really the mechanism of sort of a broad acting JAK inhibitor in a topical format actually makes a lot of sense for treating these regions too. And to your point, I don't really have to have a very complex conversation with them in terms of starting the treatment. It's really more of a, have you tried anything? I have this for you. There's no labs I have to check. I'm really sort of not super worried about many of the elements on this boxed warning. How do you kind of handle that part of the JAK piece, given that you kind of talked about topical calcineurin inhibitors, living through that bit, and now having that sort of almost repeat history again inside?
Yeah, so sometimes, you have to kind of say, you're going to see this on the box, you're going to see this on the label, if people tend to be concerned about that. And I usually bring up the side effects and the problems associated with topical corticosteroids. These are things that we do see. And I will differentiate between possible and probable, and we're looking at what side effects could be. So one of the things I want to tell patients, I love that we get a little sample, because I tell them this sample is to show tolerability. It's not to show clearance, but I will be surprised if you can't tell the difference before you get your actual prescription in. It's a mail order medication, or especially pharmacy. And just try it. Just try it. I really feel like you will be committed to it. So that is one thing. And most always, by the time a patient comes to see a dermatologist or a dermatology GNP or PA, is that they've already tried things with their primary care provider. They've been giving basics. And when they come to see us, they're looking for something with a little bit more disease specific. And I do feel like that we need to provide, again, the best therapies we have. And that's what I'll tell them. Like, in dermatology, we have access and information on the latest and greatest. And here's one I think that will work great for you. I think it's also great. There are a lot of people, I know this is off label, but because in all the trials, and ruxolitinib, it was all monotherapy. And of course, we use it in addition to some other things that they may be on, lots of systemic, biologic, or even, if it's another topical. And that sort of is like the cleanup man. If I can't get it to clear with something else, or I've tried something else, try this. It's sort of the bases are loaded, and I just need somebody to bring them in. Ruxolitinib often will do that.
I love it. It's a perfect analogy to end on. The fact that what you're thinking about, efficacy, safety, tolerability, ease of use, the ability to combine, thinking about those special sites, just try it, in the words of Melodie. That's all I got. Thanks, guys.